All right, so here's the deal. It is about 10:30 almost on Wednesday night. Still sick. I've gone from my vitamin waters to some tea. Couple things. One, the obesity video thing was a little harder than I had imagined. I thought I could outsmart YouTube, but that was sort of silly. And so I had to split it up into 4 segments. So hopefully you watched all 4 segments just now, and hopefully they all worked swimmingly well. I wanted to do asthma too. I think at the late hour and the way I'm feeling, it's going to be too hard to do the whole thing. What I did do is find and download a video about video presentation in a similar format to this one on the asthma guidelines, and it's given by a colleague of mine, Stuart Stoloff. This guy's a family physician out in Colorado, and he's the only primary care doctor on the NIH guidelines. So he actually helped draft the document and was a big player in really all of its components, and is an outspoken advocate of asthma and following guidelines. And so I thought I'd let him tell you sort of his story about the guidelines and how it was developed. So that's about a 20-minute presentation. There are a couple things, though, that I wanted you to know. Dr. Stoloff, will leave out in talking about asthma. He's strictly going to talk about the guidelines. So I want to tell you a couple things before you watch Dr. Stoloff's presentation. Hopefully I won't pass out before the end, and hopefully I can figure out the timing on this as far as there's no monitor in my webcam. So I guess I'll just have to wing it with the clock. For some reason, I do not survive this illness. I would ask the class of 2011 to posthumously award me the Golden Apple for giving a lecture on my deathbed, and that would be really, really nice. Anyway, all right, so let me talk a little bit. He will talk briefly about the epidemiology. In fact, this slide is one of his that I took, but he won't talk about the pathophysiology, which I thought it was important to discuss. The basic idea is that it's a whole inflammatory cascade. You get exposed usually to an allergen, and multiple inflammatory mediators are released in the allergic response. This goes back to the arachidonic acid pathway that you hopefully learned about in Biochem and Pharm, release of histamine, chemotactic factors, and all of these inflammatory mediators have an end organ effect causing bronchoconstriction and increased mucus secretion, etc., which lead to the symptomatology of asthma. This is a slide showing what it looks like, sort of a cross-section. You see mucus production, goblet cell hyperplasia, angiogenesis, smooth muscle hypertrophy, inflammation, all of these which lead to constrict the small airway. This is electron micrograph. We used to look at those. I don't know if you still do. This is if you remember from, I believe, microanatomy, the lung epithelium is supposed to be pseudostratified columnar epithelium, and this is not. It's a ratty epithelium with a thickened basement membrane. And again, I don't have my pointer, but there's a lot of cells there. It doesn't matter which one they are, but those cells are inflammatory cells. They shouldn't be in the lung. If you do bronchoscopy, which that's what this is a picture of, you can see what happens to the airways when you give them histamine. They simply close up. So the definition of asthma, it's a chronic inflammatory disorder. Multiple cellular elements play a role: mast cells, lymphocytes, eosinophils, neutrophils, all of the above play a role. And in susceptible individuals causes cough, wheezing, all these symptoms of shortness of breath associated with airflow obstruction. Now, asthma is considered to be reversible, but sometimes it's not. Usually with treatment on its own, but not always complete. And that's an important point in sort of a new thinking about asthma. Now, Dr. Stoloff's going to go about talk about the guidelines and sort of what to use and when, but I want to make sure you know what all the different medications are. There are rescue medications called short-acting beta agonists, or SABAs, as we say in the asthma world. There's basically sort of albuterol and levoalbuterol. Albuterol comes in 3 flavors: Ventolin HFA, Proventil HFA, and ProAir HFA. There is no more generic albuterol. I'm not sure if you're aware of this now, but because the albuterol, generic albuterols, had CFCs as their propellant, they're no longer considered environmentally friendly, and so they were phased out. And so the FDA considers all these HFA albuterols to be branded products. So there's no generic albuterol anymore. Levalbuterol is the isomer, and that's called Xopenex. They all work about the same, but the one you choose is a lot of it's going to do with the patient's insurance. Usually each insurance has picked one to be sort of their cheap one, if you will. It's a very complicated thing. If you're interested in a topic, go to my blog at drmintz.com, search on albuterol, and there's a whole explanation about the HFA conversion. The other thing that I haven't blogged about yet, but I will, is Walmart now sells basically a sample dose of albuterol. Each albuterol canister has about 200 puffs in it. They're selling one with 60, but it's only for $9 out of pocket. And so if you're not using it that frequently, if cost is an issue, that's a good option. Now the other thing that bronchodilates is long-acting beta agonists, or LABAs. There are 2 kinds in the United States. There are salmeterol, which is the brand name Ceravent, and there's formoterol, which is the brand name Fordil. I actually spelled that wrong. It's F-O-R-A-D-I-L. And there's been a lot of controversy with long-acting beta agonists. Hopefully you will recall the SMART study. This is a study that you analyzed in detail during PCL first year with the asthma case. You looked at that SMART study. That SMART study is still relevant today, still causing controversy. In fact, the FDA back in December looked at all of the long-acting beta agonist and reviewed that and came out with a position. It's not sure how they're going to act. This was just an advisory committee, but it looks like salmeterol and formoterol will no longer be indicated as sole agents for asthma, only to be used by themselves in COPD. However, they are beneficial in combination, which I'll talk about in a second, and it looks like that combining them with an inhaled corticosteroid confers safety. Again, I could talk ad nauseum about this issue. If you're interested, again, go to my blog. You can also Google Mintz and LABA, and I think I might come up in the first 10 hits, which is kind of cool when you show up and Google is, on the first time. That's kind of cool. All right, inhaled corticosteroids. Dr. Stoloff will tell you about their role, but I want to make sure you know which ones there are. There's fluticasone. The trade name is Flovent. Budesonide, which is Pulmicort. Mometazone, which is Asmanex. And then what you'll probably see a lot of is the combination ICS and LABAs. Fluticasone and salmeterol is Advair, and budesonide and formoterol is Symbicort, which is relatively new. And then finally, there's the leukotriene modifiers. The most common one is Singulair, it is a drug that a lot of people use, including pediatricians. That being said, inhaled corticosteroids, we know, are some of the best agents around. And Dr. Stoloff will tell you more about this, but they basically have been shown to work a whole lot as far as symptomatology, improving lung function, decreasing rescue medication. But there's another thing that's pretty important for inhaled corticosteroids that I will tell you in just a second.